Picture this. You've just walked out of a clinic after a gynecological procedure,
Right.
and you've got this massive stack of medical leaflets in your hand, like just a pile of paper.
Oh, yeah, the classic discharge packet.
Exactly. But you're really just trying to quickly figure out how all this impacts your daily life. Specifically, you want the answer to one highly practical question, like how soon can I safely use a tampon again?
Which is such a common question. And honestly, the advice you get can be incredibly confusing.
Right, because sometimes they say a day, sometimes they say a month. And what if I told you that one of the most strictly enforced, universally prescribed tampon rules in women's healthcare
Yeah.
isn't actually based on a single modern clinical trial?
It's really wild when you dig into it. And it's one of those inherited pieces of medical wisdom that, when you trace it back to the cellular level, reveals this massive gap between, historical caution and hard biological evidence.
And that is exactly our mission for this deep dive. We are going to untangle the medical advice across a whole variety of procedures, from like IUD fittings and biopsies.
Right. Ablations, miscarriages.
Yeah, all of it. We're going to extract the exact tampon timelines from the sources. But more importantly, we are going to explain why the rules actually change.
Because the wait times vary wildly, right? I mean,
Yeah.
from just 24 hours to a strict non-negotiable 4 weeks.
Wow, a whole month.
Yeah. And the reasoning always comes down to this fascinating mix of basic anatomy, infection prevention, and, well, physical healing. The rules completely transform depending on whether a clinician is simply, nudging a biological barrier or taking a core sample from it.
Or intentionally destroying a layer of it.
Exactly. Or just waiting for the entire organ to systemically reset.
So let's start with that first category, right? Nudging the barrier. I'm talking about getting an intrauterine device or an IUD fitted.
Probably one of the most common procedures.
Right. And for anyone familiar with their own anatomy, the fear isn't necessarily that the tampon will magically bypass the cervix and bump the IUD itself.
No, because the device sits high up in the uterus.
Right, and the tampon sits much lower down in the vaginal canal. The cervix acts as this, barrier keeping them safely apart.
Exactly.
So the concern for the listener is usually about those removal strings hanging down, right? Like, can a tampon accidentally pull out an IUD?
Which, is a totally valid mechanical concern. But before we even get to the strings, we have to look at the immediate aftermath of the insertion itself.
Okay, what happens right after?
Well, most clinics, like the WYouth NHS Trust guidelines we reviewed, they advise holding off on tampons for the first 24 to 48 hours.
Just a day or two.
Yeah. And the rationale here has everything to do with how the cervix functions. Think of it as a pressurized airlock.
Oh, an airlock. I like that better than just, a closed door.
Right, because an airlock is actively maintaining two completely different environments. The vaginal canal is this robust, non-sterile environment, right? It's populated by a complex microbiome. It's built to handle a certain bacterial load.
Right, it's doing its own thing.
Exactly. But the upper reproductive tract, so the uterus, the fallopian tubes, that is a sterile environment.
Oh, okay.
And the cervix is the airlock between them. It relies on a highly specialized, thick mucus plug to maintain that seal.
Oh,
But during an IUD insertion, the clinician has to use instruments.
like to measure things.
Yeah, a tenaculum to stabilize the cervix and a sound to measure the depth of the uterus.
So they are essentially forcing the airlock open,
Yes.
breaking that natural mucus seal, and I'm guessing creating microscopic tears in the cervical tissue just to get the device inside.
Exactly. That physical manipulation leaves the airlock temporarily compromised. So it takes roughly 24 to 48 hours for the localized inflammation to go down.
So the microtears can seal up.
Right, and for the cervical mucus to reestablish a really secure barrier, if you introduce a tampon during that window, you are essentially placing a highly absorbent, bacteria-friendly object right next to an airlock that's currently, stuck ajar.
Okay, I get that, keeping the area clear while the airlock resets. But let me push back a little here.
Sure.
Let's say we are past that 48-hour window. The airlock is totally secure. They're in completely separate rooms now.
Right.
But there's this fascinating, highly specific warning from Highland Sexual Health that we looked at, and they explicitly warn against the dry tampon.
Ah, yes, the physics of a dry tampon. It's something that rarely gets discussed in standard care, but it is critical here.
Why is it so dangerous?
Well, cotton and rayon blends are incredibly hydrophilic. I mean, they're engineered to aggressively seek out and absorb moisture.
That's their whole job.
Exactly.
Oh,
So if your post-insertion bleeding is very light, which it often is with an IUD, and you insert a high absorbency tampon just to be safe.
Oh, I see where this is going.
Yeah, that cotton matrix is going to absorb whatever minimal natural moisture is present on the vaginal walls.
So it's basically sucking the walls dry.
Right. And when it does that, the tampon expands and functionally grips the surrounding tissue.
Mm.
So when you go to pull that dry tampon out, you aren't just sliding it out smoothly.
You're pulling against the tissue.
You're creating intense mechanical drag. And while a smooth removal wouldn't bother the IUD strings at all, that extreme friction from a dry, expanded cotton cylinder, it can actually cause the tampon to snag the strings.
Oh, wow.
Yeah, the strings that are hanging down in the vaginal canal. And the force of you pulling that stuck tampon can transfer directly to the strings, which risks pulling the actual device out of place.
Okay, so the rule for IUDs is clear. Give the airlock 48 hours to reseal to prevent infection.
Yep.
And even after that, never deploy a dry tampon just to avoid the friction trap with the strings.
Precisely.
All right, so let's follow the biological mechanism forward. We just talked about nudging the airlock. But what happens when clinicians need to actively take a piece of it?
Right, so now we're moving into diagnostic territory, specifically cervical punch biopsies.
Which sounds intense.
It is a step up in localized trauma for sure. If an abnormal smear test warrants a closer look, the doctor will take a small rice-sized core sample directly from the cervical tissue.
And instantly our timeline jumps, right? Guidelines from places like North Tees and Hartlepool and Leeds teaching hospitals, they recommend waiting anywhere from 2 to 7 days before using a tampon.
Right.
I'm assuming this isn't just about the airlock being ajar anymore. Like, this is an active bleeding wound.
It is about the wound, yeah. But more importantly, it's about how clinicians force that wound to stop bleeding.
Because they don't use stitches, do they?
No, the cervix is highly vascular, so to control the bleeding from a punch biopsy, doctors use a chemical cautery, typically a substance called silver nitrate, or a specialized medical paste like Monsel's solution.
Wait, chemical cautery? That sounds like an intentional chemical burn.
I mean, functionally it is. They are shocking the blood vessels into closing. The chemical triggers this accelerated coagulation cascade.
Yeah, okay.
It bonds with the blood and tissue to instantly create a localized seal. The medical leaflets often describe it as a yellowy black plug.
A plug, not a scab.
Exactly. This isn't a normal scab like you'd get on your knee from falling down.
Yeah.
It is a fragile, chemically induced matrix, and it sits on a wet mucosal surface.
Which brings us right back to the nature of a tampon.
Mm.
If you have this fragile chemical matrix trying to heal in a wet environment,
Yeah.
inserting a rigid, expanding cylinder of cotton right up against it seems like a really bad idea.
It's a terrible idea. The cotton fibers can actually adhere to that silver nitrate plug.
Oh, no.
Yeah. So if you use a tampon too soon, removing it can physically rip that chemical seal right off the cervix.
Which just restarts the bleeding.
Exactly. It forces the body to begin that whole vascular healing process all over again.
Okay, so wait a few days for the chemical plug to do its job. Makes total sense.
Right.
But what if the diagnostics require going deeper? A lot of our sources detailed endometrial biopsies and hysteroscopies.
Yes. The deeper you go, the stricter it gets.
Right, because this is where they bypass the cervix entirely, and they pass a thin tube or a camera directly into the uterus.
Exactly.
And the clinical advice here gets significantly stricter. Like, we are seeing timelines from 48 hours up to a full week. And for a hysteroscopy, some major institutions like Guy's and St. Thomas's flat out state you should not use tampons until your next menstrual period.
Right. And that leap in the timeline, it makes complete sense when you factor in the fluid dynamics of a hysteroscopy.
Fluid dynamics. Like, I know the sources mention they use fluid to see inside, but I want to wrap my head around why that actually changes the tampon rule.
Sure. So the uterus is what we call a potential space. Under normal circumstances, the walls are touching. It's collapsed.
Like a deflated balloon.
Exactly. So to get a camera in there and actually see anything, the clinician has to pump saline solution into the uterine cavity to balloon it open.
So they're filling that sterile upper environment with fluid.
Right. And that fluid doesn't just stay up there. It has to drain out somewhere.
Through the cervix.
Yes. Through the cervix and into the vaginal canal. Remember our airlock metaphor from earlier?
Yeah.
The saline actively flushes away that protective cervical mucus plug. The canal itself has been artificially dilated wider and for a longer time than, say, an IUD insertion.
Okay.
And now you have a continuous stream of fluid connecting the non-sterile lower tract directly to the sterile upper tract.
So it's like the deeper into the house the dockers go, the longer you have to keep the front door bolted shut.
That's a perfect way to look at it.
Because if you insert a tampon while that drainage is happening, it's not just absorbing the fluid,
No.
it's creating a stationary, saturated plug in the vaginal canal that is harboring bacteria right at the base of this completely open, freshly washed biological highway.
Exactly. And that is the perfect recipe for pelvic inflammatory disease, or PID.
Wow.
The bacteria can travel retrograde, meaning upstream, via that fluid connection right into the newly traumatized uterine lining.
So that's why they say wait until your next period.
Right. By telling you to wait until your next cycle, the hospital is ensuring that the cervical canal has completely returned to its natural, tightly contracted state and that the mucosal airlock has fully regenerated over the course of a normal hormonal cycle.
Okay, we've gone from nudging the airlock to taking a core sample to literally flooding the system.
Yeah, we're escalating.
We really are. Now we need to look at the next progression. Heavy-duty healing. We are moving away from diagnostic peaks and straight into treatments that intentionally destroy large areas of tissue.
And this is where the biological stakes are at their absolute highest.
Yeah.
This is where we see the most stringent, non-negotiable rules across all the medical literature we reviewed.
I want to focus on LOETZ, large loop excision of the transformation zone.
A very common but serious procedure.
Right. For anyone who hasn't encountered this, if a biopsy finds precancerous cells, clinicians use an electrified wire loop to literally shave off a section of the cervix.
Yeah.
And every single source we looked at, from the Royal College of Obstetricians and Gynecologists to Cancer Research UK, they're completely unified on this. It is a strict 4-week ban on tampons. No exceptions.
Done.
But I have to ask, why 4 weeks? Like, if I get a deep cut on my arm, it forms a scab and heals in a week or two. Why is the cervix taking a whole month?
Well, you have to separate epidermal healing, like the skin on your arm, from mucosal healing.
Okay, how are they different?
When you cut your arm, it's exposed to dry air. So the body forms a hard, rigid crust of dried blood and platelets.
Right, a normal scab.
But the cervix is a mucosal surface. It is constantly bathed in natural fluids. It physically cannot form a hard, dry scab.
So how does it seal the wound if it can't dry out?
It forms this sloughy, gelatinous barrier over the raw tissue bed. The transformation zone, the area they're excising, is literally the junction where two entirely different types of cervical cells meet.
It's a very sensitive area to begin with.
Exactly. Searing that tissue off leaves a massive, highly vascular wound. And because the scab is soft and wet, it takes significantly longer for the underlying capillary beds to rebuild themselves.
Actually, one of the leaflets noted a very specific symptom during this process. Around day 10, the discharge might uniquely look like coffee granules.
Yes, the coffee granule appearance. That's the cellular debris from that soft scab finally breaking down as the new tissue underneath stabilizes.
But I'm guessing that stabilization is incredibly fragile.
Oh, incredibly. Which brings us back to the friction problem we talked about earlier, but on a much more dangerous scale.
A catastrophic scale, potentially, right?
Yes. If you introduce a tampon during this 4-week window, the abrasive friction of the cotton against that wet, gelatinous scab can easily shear it off.
Ouch.
And you aren't just interrupting the healing, you are risking delayed hemorrhaging.
Wait, really?
Yes. You're ripping the seal off newly forming blood vessels that were previously cauterized by the electric loop. That can lead to severe, rapid blood loss that requires emergency surgical intervention to stop.
So at this stage, it's not just about bacteria entering an open doorway. It's about not physically rubbing a fresh internal wound.
Exactly. The mechanical friction of a tampon against healing tissue is the primary danger here. You cannot put an abrasive cotton cylinder against a fragile, wet vascular seal.
The mechanics of that are terrifying, but it makes absolute sense why the 4-week rule is a hard stop.
Yeah.
And we saw similar extended timelines for internal tissue destruction, right? Like endometrial ablation, where they use heat or cold to destroy the uterine lining.
Right. With ablation, the internal tissue destruction triggers a massive inflammatory response. Patients experience a continuous watery, blood-tinged discharge as the necrotic tissue, the destroyed lining, breaks down and leaves the body.
And how long do they wait for that?
The general guidance is a 1 to 2 week wait. But crucially, the biological metric is to wait until that specific post-operative discharge has completely stopped.
Just ensuring the internal cavity has finished purging all the cellular debris. We even saw this principle applied to non-surgical thermal treatments. The Women's Health Clinic guidelines for vaginal laser or radiofrequency treatments noted an absolute restriction on tampons for the first 3 days and a week-long wait overall.
Right, because the laser causes microthermal injuries to the vaginal walls to stimulate collagen.
And inserting a tampon would mean dragging a dry cotton matrix directly across highly inflamed, thermally compromised vaginal mucosa.
Yes, again, it is all about avoiding mechanical abrasion during the acute inflammatory phase of healing.
Which perfectly transitions us into our final section. And honestly, this is where we found the biggest revelation in our entire deep dive.
It really changes how you look at the guidelines.
It does. We are shifting from localized treatments, like burring off a small area of cells, to profound systemic uterine events. I am talking about the body executing a full reset to return to a non-pregnant state, miscarriage and abortion.
Right, these events involve the entire reproductive system. The physiological changes are systemic, not just localized to a single punch biopsy site or a cervical loop excision.
And if you look at the standard clinical advice from major institutions like UCSF, UCLA, the NHS, the mandate seems incredibly clear. They uniformly advise patients to stick exclusively to pads and avoid tampons for 1 to 2 weeks, or until the heavy bleeding fully stops.
Yeah, and the theoretical mechanism behind that guidance is very similar to what we discussed with the hysteroscopy.
Yep.
Following a pregnancy event, the cervix is dilated to allow tissue and blood to pass. The traditional medical concern is that inserting a tampon could push natural vaginal flora upstream through that open airlock and into the uterus, triggering a massive pelvic infection.
But this is where the deep dive took a massive turn. When we reviewed the specific medical literature provided by the advocacy and information group in edana.com, they highlighted a nuance that fundamentally shifts how we view this rule.
Right.
Because you just said the theoretical mechanism, and I feel like that word is doing a lot of heavy lifting here.
It is the crux of the whole issue. What Edana points out, and what modern reproductive researchers are increasingly highlighting, is that this strict no tampons for 2 weeks guidance is largely based on historical inherited caution, not on randomized clinical trials.
Wait, so this medical rule isn't an absolute biological law, it's more of a better safe than sorry guideline.
Exactly. Because historically, before the advent of modern antibiotics and advanced sonography, post-abortive infections were a leading cause of maternal mortality.
Oh, wow.
Yeah, so the medical community adopted a stance of extreme behavioral restriction to mitigate any perceived risk.
But if the vagina isn't a sterile environment anyway, why does the presence of an open cervix suddenly make tampon use an absolute red zone?
That's the thing. Recent data suggests that once the acute, heavy passing of tissue is complete, there is no statistically significant difference in infection rates between patients who use tampons and those who use pads.
That is wild. So the paradigm is shifting away from strict calendar days.
Yes, moving toward active symptom monitoring. And this is where the real danger of tampon use during a systemic uterine reset lies.
Okay.
It actually isn't about the bacteria. It's about measurement.
Measurement. Oh, I see. Because if you have a tampon internally absorbing the blood, you lose all visual data on how fast you are bleeding.
Precisely. During the active phase of a miscarriage or a medical abortion, clinicians monitor the danger of hemorrhage by volume.
So they are looking for specific warning signs.
Right. The clinical warning sign of an emergency is soaking through 2 heavy maxi pads an hour for 2 consecutive hours.
And if you are using a high-capacity tampon or a menstrual cup?
You physically cannot measure that rate of blood loss. You might be actively hemorrhaging and not realize it until you become symptomatic from blood volume depletion.
So the pad isn't just about preventing an infection pathway. It is a critical diagnostic tool for the patient to monitor their own systemic reset.
Exactly. And once that diagnostic tool tells you that the heavy bleeding has slowed down to light, manageable spotting, meaning the hemorrhage risk has passed, the modern evidence-based approach suggests you can switch back to tampons whenever it feels physically comfortable for your mucosal tissue.
You don't just arbitrarily wait 14 days to cross days off a calendar.
No, listening to your own body's bleeding volume is actually a much better metric.
That is incredibly empowering. It shifts the power dynamic. It tells the listener to use their own body's volume metrics rather than a blanket historical timeline.
It really does.
So let's pull all these biological threads together. We set out to answer exactly when you can use a tampon after treatment, and the answer is entirely dictated by the physics of your healing tissue.
Right. To map it out clinically, you are looking at a 48-hour wait for an IUD to let the cervical microtears seal followed by a strict ban on dry tampons to avoid friction dragging the strings.
And for a simple punch biopsy, give the chemical silver nitrate plug a few days to work without cotton adhering to it.
Yes. If the procedure involves artificial fluid dilation, like a hysteroscopy, you are waiting until your next period so the bacterial highway is fully closed.
Right. And for systemic resets like miscarriages, you rely on pads purely as a visual diagnostic tool until the hemorrhage risk passes.
And finally, if you have an excision like a LELTZ, it is an absolute non-negotiable 4 weeks to prevent the catastrophic shearing of a wet vascular scab. The mechanics change, but the core theme is protecting the mucosal barrier while it rebuilds.
But, the revelation about the 2-week abortion rule leaves us with something much deeper to consider.
Yeah, it really does.
We discovered today that some of the most rigid, universally prescribed advice in post-procedure care is rooted more in historical anxiety than in rigorous modern data.
Which is a huge shift in perspective.
It begs a massive question for you to explore the next time you are handed a stack of medical leaflets. How much of the standard rules in women's healthcare are based on actual cellular evidence, and how much is simply inherited caution passed down through generations of practitioners without ever being challenged? Keep questioning the rules and keep diving deep.